My name is Trish Ware, and I am obsessed with all things pregnancy and birth, and helping you to navigate both the practical and the magical seasons of this journey called motherhood. I'm an all-day coffee-sipping mama of 7. I've had the amazing privilege of delivering many babies in my 15-plus year career as a labor and delivery nurse and as a mama of 7. I'm here to help you take the guesswork out of childbirth so you can make the choices that are right for you and your baby. Quick note, this podcast is for educational purposes only and does not replace your medical advice. Check out our full disclaimer at the bottom of the show notes. Good morning, everyone. I am pumped up this morning. You guys, I am fangirling so hard right now. I am so excited to introduce our guest. I just have to say, when I saw an email from this guest about coming on, I literally screenshot it and sent it to my doula team and sent it to the people who come into my community help with my mamas. And I was like, oh my God. So today's guest is Rebecca Dekker, and she is evidence-based birth. That is her. And I am just so happy you're here. Thank you so much for coming on.
Yeah, thank you so much for having me. And thank you for the work that you do educating parents around the world. It's just so exciting to talk with a fellow nurse who shares like the same mission. So yeah.
I know. I love it so much. And it just, I don't know if you know, but I also coach new business owners and business owners who are scaling their businesses. And the majority of the women I work with are in the birth world in some capacity. And I've had other people ask me, like, why are you coaching competitors, basically? And I'm like, no, our goal is to change the birth culture. And someone may be like, I'm older than most of the other educators right now, you know, I'm like, some might want a mama, someone might want a sister, you know, and so I just love that we can all work with that same goal.
Mm-hmm. It's definitely the abundance mindset is what I believe in as well.
Me too. And the truth is, I started this because of what I was seeing at bedside. And so Rebecca and I started to chat before I started recording, and I was like, no, let's talk about this. So first, I know everyone listening knows a bit about my story, but they may not know your story. So I would love for you to go way back and tell us your story.
Sure. So mine's a little bit different in that I don't think my story started at the bedside. It started with my own birth experiences, and because I did not have a history as a labor and delivery nurse, but I had practiced as a nurse, and I was in grad school, and I got pregnant with my first baby. And I had to give birth at the university where I was studying, and so I just assumed that I would get really good care because, you know, you think academic medical center, this is where all this cutting edge research is taking place. And in the College of Nursing where I was teaching and doing research, we were all about evidence-based care. It was like what we lived and breathed was like, what does the research say? How can we put this into practice? So I just kind of assumed that that was happening on labor and delivery. And so I didn't do a lot of preparation. And then when I got there at 39 and a half weeks and I was totally healthy, I was really surprised when I was being treated as if I had some kind of like congestive heart failure condition. You know, I was like on strict bed rest, NPO, bedpan. They wouldn't even let me out of bed to use the bathroom. I was hooked up to all kinds of monitors and IVs. And I just all of a sudden found myself like as a sick patient. And so that really struck me because I knew in my gut, in my intuition, that I was not sick, that everything was fine. So I was kind of confused as to what was going on, but I was willing to go with the flow because I didn't want to be one of those patients that they talk about.
Oh, I say that all the time. Those people.
We all know we all know who they
Yeah.
are. We all know about the gossip at the nurses' stations, and we all know that they don't tend to get the best care. Like if you're difficult and you make the staff's lives more difficult, you know, so I just wanted to be nice. And that actually has been ingrained to me from a young age, is to be pleasant, to be polite. You know, that was part of how I was raised in the South.
Oh,
And
hello.
yeah.
My mother's from Kentucky.
Yeah. So, that was an interesting experience in that I did try to push back on a few things, but I was really careful on what I pushed back on. And in the end, I ended up having every intervention except for a cesarean. I had Pitocin, epidural, continuous monitoring, IV fluids, and a vacuum assisted delivery. And then, I went through all of that and I was okay with all of that. But then something happened that made me really question everything. And that was they took my baby away for 3 hours, even though her 5-minute APGAR was normal, even though she was crying and pink and everything. And I kept putting my call light on. Can I have my baby back? Can I have my baby back? I need to breastfeed. I want to see my baby. And because I'd had the epidural and I couldn't walk, I couldn't go running down the hall demanding. All I had was my call light, which I kept putting it on, but it was the middle of the night and they were short staffed. And I think they just didn't prioritize putting us together. So when I finally got my baby back, she was exhausted. I was exhausted. It had been a very long labor experience where I had not been allowed to eat or drink anything for 24 hours. And I had pushed for more than 3 hours and I just felt like I'd been run over by a truck. And that was how I entered parenthood. At the time, though, I had a glow. I was very much happy with how my birth turned out. And sometimes I think when people are really naive, they just assume I made it out alive. That's the bare minimum. That's all I can expect. And it wasn't until about a year later that I started questioning everything that happened to me. And because I was getting my PhD and I was in all of the research, I was like, I'm just going to start looking at the research. So I made a bullet point list on a Word document with every single thing that happened from the moment I stepped into the hospital. And I started doing literature reviews on everything. And I was really surprised to find that most of what happened to me has either been shown by evidence to be not helpful for a healthy first-time birthing person or in some cases harmful, such as making me lie on my back for 24 hours. And then I didn't need evidence to tell me that it's harmful to take away, to separate you from your baby. But I found there's actual evidence showing it is really harmful as well. And, I think humans, we are resilient. Moms and babies, we can overcome these challenges. We can still bond with our babies, but we shouldn't be making it harder, So that was kind of what inspired me the second time to do things completely differently with a different model of care with a midwife. And I left that second experience and the contrast was so stark, where in one, I was just kind of steamrolled into all of these things. And then the other, I felt empowered. I was making choices. I was surrounded by people who were already aligned with what I wanted for that birth. And the difference was so stark that I just felt like I had to do something. And so that's when I started taking the research I'd been gathering just for my own personal use and putting it online. And that became evidence-based birth.
Which is so amazing. And I wanted to interject one thing.
Yeah.
As a labor and delivery nurse, one thing that you said that I feel can go another way is being that person. And what I encourage my students is that, and I teach them how to fire their nurse in a way that's how they might end up being super close to her, because we as labor and delivery nurses might come to work bearing our own problems and we don't even realize that, and we might be the best nurse in the world. So I have them walk through that. But I will tell you, from labor and delivery for 16 years, traveling all over the country, that if there's someone on the floor like me, I get that person. And usually, because we all know hospitals want good reviews, right? They want good, the charge nurse wants the patient to ultimately be happy. So what I would tell you guys, it's okay to be that person. And most of the time, you're going to get the most patient aligned nurse. Like, they would always give me her. And then I would bond for life with them and still communicate with them. So I just want you guys to, who cares if they're at the desk talking about you? The nurses who really care about the birth process, the natural process, the mom's rights, we're at the desk advocating for you as well.
Yeah, and I think it's changed a lot in the 15 years. And I do agree. I don't want to discourage anyone from speaking up. I think a lot of this was just in my own head.
No, I think it's in all of
I
ours.
had to address my own, upbringing and cultural indoctrination of being that nice person who doesn't speak up. And I think also there are some really strong instincts I was feeling vulnerable, so I didn't want to make waves. And now I know you can't go through life, doing parenting that way. You have to use your voice. And so for one thing I'm really passionate about, and I think you are too, Trish, is helping people find their voice. Because for a lot of people, having a baby is their first time in the hospital. And, I was really focused on being nice, but if I could do it again, I would have focused on building a connection with the team and advocating myself in a respectful way and knowing more what I wanted. Like I didn't really know what I didn't know, so I was just kind of going with the flow, which what I didn't know then, but I know now is if you just kind of do the go with the flow thing, you kind of get the bottom denominator of care. You're not going to get what might make you really happy.
Yeah.
So,
and I love that you brought all this up because I know from working with thousands of women that we also want, like, there's this weird thing that happens when you meet your labor nurse and she's a significant part of this event and you really want her to like you. There's that going on internally as well for a lot of women. And like you said, we have been, now I will say my daughter's generation, they're changing this a little. Like they don't care as much as we did about being obedient and going with the flow, but which I'm very glad. But like you said, there's a way to do it. And you use those same skills that you use everywhere else, but it is very disconcerting to get to a hospital room. They strap you with all these things. They put a hospital gown on you
and put you in bed.
Yeah,
put
which
a bracelet on your arm.
Yeah, makes you, because you've only maybe seen your grandma in bed like this with a hospital bracelet, or, when someone has been sick or had an accident. And like you said, for most women, it's the first time they've been a hospital patient. But I really am, I do feel that the culture is changing somewhat. And I think a lot of that has to do with social media because hospitals, nurses, providers are getting called out publicly. And I think it's causing them to have to question themselves as well in some ways.
True. I do think there is a developmental phase in life. You get more comfortable with your voice. And some people start off that way. They, if you ever go to a high school class, you'll see there's the students who are not afraid to use their voice. And maybe that's your daughter you can picture. Then there's the students who may speak up if they feel really called to. And then there's the students who don't say a word, right? And they just kind of want to fly under the radar. And so I think part of it is age, part of it might be your personality, your upbringing, but learning how to use your voice is critical, not just for your own health, but for your child everything. And your whole family. Because
and learning how to do it.
Birth, like you're going to have to speak up throughout the rest of raising this child.
Yeah, and learning how to do it in a way that brings change and not conflict. There's a different in that as well. Being bold, but doing it in a way that brings a good positive thing, Right. So I love this so much. So you started the blog, I'm assuming, and tell us where it went from there.
It just it picked up steam immediately, like within the first week or two. And then the traffic just kept doubling every month until I realized that I felt like I was like riding this wave of a movement where people wanted accurate information to make choices. They wanted more options and they were starting to be willing to speak up for it. And the other thing that happened was that doulas really latched on to evidence-based birth because they were feeling really disempowered at the time. And they were going with their clients, accompanying them to hospitals where their clients were not receiving safe care and feeling somewhat, traumatized by this. And so doulas also were like, wow, evidence-based birth is something we can use to educate our clients. So, basically what I was trying to do is take the research and make it publicly available so that anybody can understand it or access it. It's not behind a paywall anymore. You can understand it if you want to learn about something. And that kind of puts, I love it because it helps educate the healthcare workers, and then it helps educate the families, and that kind of levels the playing field. So you don't have as much of a power imbalance in the room or in your prenatal visits. Like, you can access the same research that your doctor might be able to if they looked something up. So that's something that was a really key part of it. And then we started a podcast, of course, and I have a book, but it just kind of kept growing.
No. Stop.
Yeah.
Slow down. Talk about that book.
Yeah, it's
because that book is amazing.
Thank you. It's called Babies Are Not Pizzas. They're Born, Not Delivered. And
I love it. It's so clever.
It's basically my journey through kind of uncovering everything that was going on in the maternity care system, and talks a little bit more about how I eventually had to decide, at the time I started evidence-based birth, I was a nursing professor. I was really involved in teaching the next generation of nurses and doing research and getting large grants to do studies. And then I had to decide, like, this evidence-based birth thing was just going crazy.
Exploding.
So what do I do?
Yeah.
Yeah. And goes into more depth with my birth stories and those of my friends and family. And yeah, that was a key period of my life.
Yeah, I love your book. I recommend it all the time. It's a great book. And it's such a perfect title.
It was actually the title of a college class I was teaching. So I love college students. People especially those who are younger, they're just so much fun to be around because
it's so much energy.
Yeah, it's so much energy, and they're questioning everything. And so the honors department asked me to create like an honors seminar student class for honor students, and I created that class. I decided to call it Babies Are Not Pizzas, They're Born, Not Delivered. And it always filled up immediately, and then I would have emails from students begging me to get in.
Oh, I would have been that one.
It was amazing how many people wanted to take that class. It really, and they still reach out to me sometimes. They send me emails, hey, Dr. Dekker, and they give me updates on their lives, and they're going on to have pregnancies and babies now. So it's just fun to see.
That's amazing.
Yeah. And some of them have turned into midwives and OBs and.
Oh, nice.
Yeah.
Well, I love it so much. And I was just thinking, when I started my blog, I was so like, I can remember, and I tell my students, and part of my story is, and I can almost smell her labor room, the way I felt in the last straw. Like, I'm done. I've got to do something. And I remember sitting in my car, and I am not kidding when I tell you I am the most technically challenged person. Like, we didn't really use computers when I went to college, like I did paper charting, and I was like, what do I do? And I always say all the time that they were as hungry for that information as I was to give it. And I had the same experience. My blog just exploded the first month, and I was like, wait, what? And, I have a particular style of how I speak and teach. And I was like, oh, okay. And I just think that we as women are ready to be more audacious and more bold and more in charge. And, that's one of the things I say to them all the time. Like, you're the birth queen. Like, this is your room. Without you in the room, the birth doesn't happen. Take your power back. And just, it's not a sickness. It's not an illness. It's a natural process. But they always joke and say, I'm crunchy with a side of medical. I also very much respect the interventions. And I'm so grateful for the interventions that we have available to us as well. But when they're used, I always tell my girls, not out of convenience or curiosity. They're when they're needed. But you have to know. You have to understand, like, when they are needed, when they might not be needed. And you have to be able to just ask questions and feel confident in that. So I'd love to ask you a few questions about different things that people, like my most common questions.
Sure.
And My most common question I get, these are always about inductions, always, mostly. And one of the ones that we try to navigate with our students is getting induced just because you have GDM, just because you're gestational diabetic.
Okay.
And I'd love to just hear your thoughts on that.
Okay, good. Well, give me a second to pull that up because, I don't want to talk without having the facts in front of me so we do have an article all about that at Evidence-Based Birth if you want to send people to it or anybody
I have
want to
it
check
linked
out.
in my birth class.
Yeah, ebirth.com/inducing GDM. And so gestational diabetes comes up a lot because a lot of people have it. Now, there's different cutoffs for when you could be diagnosed. Some cutoffs, maybe 7% of people would have gestational diabetes. Some cutoffs, 17% would have it. And that's because it exists on a spectrum. There's no one blood sugar that is like this point is where it's a problem. They have to kind of draw the line somewhere, and different people draw the line different places. So it's pretty common to have an induction offered for gestational diabetes, but we don't have a lot of data on that. And I think the reason it's offered is because there is a higher risk of pregnancy complications with gestational diabetes. But we want to ask, what does the evidence say? Does that help or not? So we do have a Cochrane review, which is where they take all the randomized trials on a subject and put them together. And they looked at a planned early birth at or near term, so between 37 and 40 weeks, versus kind of waiting until labor starts on its own. And there's actually only been one randomized trial on this subject so far that I know of. It is called the GenXmall trial, which is, I don't know why they picked that.
Yeah.
But it was an international trial. It took place in Italy, Slovenia, and Israel. And they had 214 participants randomly assigned to be induced between 38 and 39 weeks. And the other 211 participants were randomly assigned to wait until at least 41 weeks before they were induced. And they found, people often think, well, this induction is for the baby, to help the baby. But they found no differences between the groups in the number of large babies or the risks of the shoulders being stuck, breathing problems, low blood sugar, or needing intensive care. And there were more babies in the early induction group that experienced jaundice. The rates of jaundice were 2 times higher. And then when they looked at the mothers, there was no difference between groups in the rate of cesarean and needing forceps or vacuum and having a postpartum hemorrhage, needing intensive care, or intact perineum. And there were no deaths in the study. So, that's what we have in terms of randomized trials. In terms of the observational studies, there is one really large study that included more than 8,000 people. They found that inducing labor at 38 or 39 weeks for gestational diabetes is linked to a lower rate of cesareans, less or fewer cases of preeclampsia, and higher rates of needing an epidural compared to waiting for labor to start on its own. And when they looked exclusively at first-time mothers, they found no benefit to the 38-week induction. They did find that 39 weeks was linked to a lower rate of cesareans. So kind of to summarize these studies, we don't have definitive evidence showing that one path is better than the other. And I think one of the things you need to understand is that the outcomes of gestational diabetes are often dependent on how well the treatment has worked. So if you have been able to manage your blood sugars and keep them in kind of a safer range, that has been shown over and over again to improve outcomes both for you and for your baby. So it might be that maybe there's less of a need for an induction if you've been able to manage, let's say you've managed your blood sugars, they've stayed in a normal range with exercise and nutrition. Then maybe the induction conversation isn't as relevant to you because your blood sugars have been normal, right? So I think individualized care is really important. And I think we're seeing more towards this leaning of 39 weeks instead of 38 weeks. But at this time, there's not really any definitive evidence on this. It really comes down to at EBV, we talk about evidence-based care kind of being like a three-legged stool. It's like you have the research evidence is one leg, having a provider who can help you interpret that evidence and apply it to your unique situation. And then the third leg is you, like your preferences, your goals, and your values. Maybe you prefer a 39-week induction because maybe you have a history of a previous pregnancy loss, or there's some other social reason you want to be induced at 39 weeks. But maybe you've had an induction in the past and you really didn't like it and you want to avoid it. So that also could play into it. So your preferences do matter. And unfortunately, we do see a lot of pressure to induce, even though the evidence isn't really clear.
Yeah, and I love that you said individualized, because that's pretty much what I tell my moms. If you're diet controlled, or your blood sugars are in control, your baby is doing well, and you are confident in your provider, have a conversation. Talk about your specific situation. And I'm with you. If it's if mom is preferring, and I don't even care what her reason is, if it for her mental well-being she prefers to be induced, then I'll support that. That's her choice. But I do agree with just about all of it, that it needs to be an individualized, let's talk about her. Because even, and we could go on and on with all the things, IVF, big baby, all the different things. And what I recommend to my students is that they start having early and often conversations with their provider and ask them to base it on what's going on with them. And then I also encourage my students, okay, so maybe their provider is very heavily leaning into being induced at 39 weeks. They do not want to be induced at 39 weeks. They are, their blood sugars are in limits for them. Baby's doing well. They're doing well. Then make some baby step compromises, maybe agree to more NSTs, or maybe come in for another BPP, something where you're working with them, not just like, no, I'm not going to be induced. That's that. Because I also think the opposite side is, God forbid something were to happen, because you and I both know loss happens. It happens whether you have anything else going on or not. I just had a student lose her baby 40 weeks in one day 2 days ago. We're all heartbroken. She had, low risk, nothing. So that can happen. But let's say your doctor is pressuring you to be induced, and then you just go balls to the walls. No, not doing it, not coming in for more tests, not doing all those things, and something were to happen. There's also that can play out as well. So I usually encourage my students to work with them. And, you are considered high risk, so go in for more NSTs and testing. Make sure you and baby are doing well, and then you navigate from there. So if baby didn't do well on that NST or BPP, then you make a decision based on that. Like we don't refuse things just because we can, and we don't accept things just because we should.
I think one good question when you're having conversations with somebody who's pressuring for something is to say, I'd really like to see like the guidelines from your professional organization on that. Because I hate to say it, but some doctors don't know the latest guidelines, and it will force them,
or they manipulate it. So I tell my students to say, I always tell them, first of all, I teach them how to read the room, right? So if your doctor is rushing in and like, we need to send you to labor and delivery right now, and it's emergent, it's a little different. But if your doctor is telling you they recommending this or that,
we want you to schedule it next week.
Yeah, we always say, ask them to go print the study that is backing up what they're saying, and tell them you will take it home, not right there, take it home, and without attached emotions, read through it. And what happens a lot of times with my students is the doctor will highlight what supports them, but then when they read the whole study, they realize, wait, this does not support what you're saying. And then when they come back and they have a discussion, they're not like, amped up and emotional. So we definitely do that. We tell them, show me.
Yeah. Next time I come in, I really need to see that, because I'm not going to schedule anything without, seeing it in writing.
Yeah, and we have them printed out then and there and take it home.
Oh,
And
that's
and
a good
we
idea. Let me
we
take it home
link
and look at it. Yeah.
we link to your articles and to studies all over the birth course. My students always say that their nurses are like, "Are you an L&D nurse? Like, how do you know all this? Are you a doula?" Because I want them to know what I know. I'm the same as you. Like, let's not have any walls between that. Like, go in knowing the things so that you can navigate these and their partner, because I tell my girls all the time, when you're in labor, your only job is to labor. Like, you don't need to fight all the evidence or any of that. Like, that's your partner's spot now. So we're getting close to 30 minutes, and like I told you, I usually like to keep these short and sweet because I know my mamas and they drop off. So I'd love for you to tell everyone where they can find you. And well, we've said already evidence-based birth, but do you hang out on Instagram or any other social platform more than the other?
Yeah, you can follow us at EB Birth on Instagram. And then something you were saying earlier about, there was just one thing you said that I wanted to point out, and that is, if your provider is putting pressure on something for you and you don't want it, and the evidence isn't really clear either way, I think you got to understand that this provider is more confident and comfortable with 39-week inductions, and you might be better off, if it's early enough, switching care, because if your provider is very antsy and anxious about you waiting till 40 weeks and 6 days with gestational diabetes, then you might see them more likely to suggest a cesarean when you're in labor if it's taking a little longer than they like. So just to keep that in mind, that the providers who prefer those earlier inductions or elective inductions, that's what they prefer. If you kind of go outside their realms of their comfort zone, they're going to get more and more anxious. And there's a lot of subjective decision making that happens in labor. So just keep that in mind, that if you really feel like you're butting heads with your provider, if it's possible to switch providers, sometimes that will help alleviate that like kind of power struggle.
I love that so much. And that's why I tell them early and often, have these conversations. Don't wait until your third trimester, like start, which again is why my birth classes start at the beginning of pregnancy. And we have people who join us when they're trying to conceive. They're not pregnant yet. We hang out with them every week on Zoom, well, 3 times a month on Zoom. But that's what I say too. And watch their body language, like listen to what they're really saying. So if you're trying to talk about something that's really important to you and you're 22 weeks and they're like, "Oh, we can talk about that later. We don't need to be talking about that now." That is a red flag.
Exactly.
Because you don't know what they really feel about it. And in defense of these providers who are comfortable with that, I tell my girls all the time, these providers aren't evil. Like, I'm not saying like they're just horrible people. This is their job. And like all of us, we get comfortable in our routine and what makes us feel safe in our routine. So that is okay for them, but maybe not okay for you. And it's okay to switch. But I'll tell you, I've had a lot of students lately that have had a hard time switching providers. So just really be mindful of that when you guys get pregnant. If you're listening early on, interview these providers. Don't go in, like, you have a right to go in and interview them across from a desk, like person to person, and make a really good decision that's aligned with you. The thing that scares me about that is that most of them don't know really what they want yet or what's even available to them at the beginning of pregnancy. So anyway, thank you so much for coming. I am so happy that you came today. Thank you.
Thank you, Trish.
Thank you so much for tuning in to today's episode of The Birth Experience with Labor Nurse Mama. It's been such an honor to have Dr. Rebecca Dekker, the founder of Evidence-Based Birth. I hope you loved listening to it. Her insights on birth rights and your birth experience, truly eye-opening and invaluable. The birth worker world and parents everywhere thank her for her invaluable resources. Don't forget to subscribe to The Birth Experience wherever you listen to podcasts. And if you love this episode, please leave a review. Take 2 minutes, leave a review. Your support helps us bring more amazing guests like Dr. Dekker to the show. Now, again, every Friday morning. I'll see you again next Friday. Bye for now.